lunchtime window, like 11 a.m. to 1, that the bicycles are actually like free for use. I know Des Moines has something like that. So, okay, so I have two more things here. We have the racial residential segregation that I talked about earlier. There's already a policy underway to kind of address that, but I have a few tweaks that might help out with it. The Department of Housing and Urban Development has a housing choice vouchers program, which basically gives vouchers to low-income families, elderly people, the disabled, to help them buy homes in the private housing market. And it's administered by what are called public housing agencies, pretty simple, PHAs. And basically they tend to have a backlog on these things. There's a lot of people who want these vouchers to help them get a home. So there's always tends to be a backlog with the public housing agencies. And they have what are called local preferences, which are these preferences that say if you meet this and this, we'll kind of give you a priority on the waiting list or on getting a voucher. So I say we use these local preferences to help address some of the health effects of racial residential segregation. One would be using the equity atlases that I was discussing earlier to pinpoint areas of neighborhoods that have the most healthy food outlets and also have the most access to public transportation. I mean, ideally you want to have, obviously, you want to have healthy food outlets everywhere, you want to have public transportation everywhere, but for the moment until we get there, use the equity atlas to determine where the prime points are where public transportation and healthy food outlets are, and then basically say to the people on the waiting lists that if you agree to move to one of these areas pinpointed by our atlas, we'll give you a higher priority on getting off the wait list and getting a voucher. So it's an incentive for them to move to those kind of areas, and that'll be good for them obviously because these folks tend to come from the neighborhoods that don't have public transportation, healthy food options, and this will help them. This will accelerate the transition from an unhealthy lifestyle to a more healthy lifestyle by putting them right in the middle of where the healthy food is at and where the transportation options are at. So, and then I want to finish up here. Let me make sure I'm not running out of time. Oh crap! Shit. All right. Well, all right. I'll finish up here. I'm still within the technical time. The last thing I have here is the infrastructure bank. And you might have heard of an infrastructure bank before. It was touted a lot during the Obama administration and then mentioned by the Trump administration. It's the idea where the federal government basically has a pot of funds and then state and local governments can apply to the bank to get funds for infrastructure projects. That's the basic gist of it. What I would do is basically, if we establish an infrastructure bank as part of infrastructure reform, I would say we should tie the conditions for getting funds for infrastructure projects to having some sort of public health benefit. So like for example, if they want to build a new bridge, that's great, but you need to have sidewalks that have enough room for bicyclists, joggers, and pedestrians. Or with roads, like you need to make sure you have bike lanes so that bicyclists can get around. And then they should especially prioritize, the infrastructure bank should especially prioritize neighborhoods that put an emphasis on public transit, so that folks can get to the supermarket and whatnot. All right, so those policies, what I proposed here, they're pretty targeted policies. They're mostly flexible for the most part. They're amenable to compromise. They're not too set in stone, but they kind of give a framework with which we can start to address income, neighborhood, race, these social determinants. We start to address their effects on health outcomes and contribution to health disparities in the United States. Yeah, I think that's all I got. So I'll take questions now. I tried to, there was a lot of stuff I wanted to talk about. So sorry if I didn't make everything clear. But now it's time for questions.
A whole bunch of questions, please.
I drank some water first, but yeah, sorry I asked questions. I'm not used to giving that long speech, so.
So, research on the social determinants of health has been going on since about the mid-1980s.
Mm-hmm. Yes.
And so for about the last 30 years or so, there have been lots and lots of policy recommendations. how do your policy recommendations differ from the majority of recommendations that have come out to this point?
Let's see. Well, I came up with these based, so I reviewed all this literature and whatnot. I went through and I kind of found the broad level, how they work theoretically, and then I kind of went through to see what the mechanisms for each one in, like, the real world, like, income and education. And then I came up with these policies. I did not, in my review of the literature, the policies I have here, for the most part, are fairly new. I mean, obviously, the universal pre-K is not a new idea, but I think I proposed an innovative way to kind of fund that.
Well, your policy, your suggestion.
Some of these policies are brand new, or brand new as they get. Some of them are more a mixture.
From what lots of other people have recommended in response to the issues with regard to the social determinants of health. So I'm wondering why you've chosen to go the direction you have, and why you're rejecting those other policies.
Rejecting the other policies. Can you give me an example? I mean, I don't feel like. Okay. Well, I'm a little confused. So
you were looking more at the theory, and then you were working up your own policies,
yes,
as opposed
correct.
to looking to see what sort of policies
Sure.
have already been put up.
Okay, great. Yeah.
Okay.
Yeah, and so yeah. So I mean, that was the whole point, was to kind of review what the research is, and then come up with my own policies, because, like, what would have been the point if I just copied someone else's policy? It's like,
Okay.
So I hope I explained myself well there, but yeah.
Another quick question is, at the beginning of your talk, you mentioned talk of the Affordable Care Act.
Yeah, I have a obsession with it, but continue.
Most of the research suggests that, in fact, medical care and sort of formal health care really doesn't have that much of an impact on a nation's health at all.
Well, right, that's what I'm saying. Sorry, continue. I'm sorry, I should cut you off. I'm sorry.
So my question is, why voice concern or dismay over the lack of passage of any sort of Affordable Health Care Act? I mean, if you look at Britain, where they have national health insurance, that's in fact where most of the research has happened with social determinants of health. So why should we even care about national health insurance?
Well, I'm glad you asked that question, because that's really up my wheelhouse. I mean, I hope I'm getting at what you're asking here. But I mean, without health insurance, I mean, if folks don't have health insurance, with the way medical costs are with, like, prescription drugs and whatnot, and treatments for cancer, and I mean, look, my mom had pancreatic cancer, and, like, the chemotherapy treatments were like tens of thousands of dollars, and so I wouldn't have been able to pay that out of pocket. I wouldn't be here at Drake University, so without health insurance to cover those costs, a lot of Americans would go bankrupt. So that's why you need insurance coverage, and that's why I expressed dismay at the efforts to roll back.
The argument with regard to the social determinants of health
is that it goes beyond that, yes. Sorry.
No, the argument for the social determinants of health says that the amount of money we spend on health care, sort of officially on medical care, does really virtually nothing in terms of helping people's health. And that if instead we spent that same amount of money addressing the things that actually cause us to get sick, as opposed to addressing why we get sick in the first place, that we would, that would help us a lot more. And the reason I bring up Britain is that Britain has national health care, and their health outcomes don't seem to be any better than ours. That's part of the drive behind the social determinants of health movement. So while it's true that some people, so right now we're spending a huge amount, the United States spends more money on health care than any other country. If we were to spend all of that money on the things that are actually causing us to get sick,
right,
which are predominant, so why should we care about health insurance given the evidence that health insurance doesn't really seem to affect people's health outcomes all that much on a population level?
Well, I think we have a little disagreement about a few things here. I mean, for one thing, in my research I found that the United Kingdom, the life expectancy rate and the infant mortality rate in the United Kingdom was better than ours. So they're getting better health outcomes on those key health indicators. Whether that's directly attributable to the national health insurance system is another matter, but the UK is definitely ahead of us in some regards on health outcomes. I mean, to your point about the healthcare spending, I agree that the U.S. is not getting its bang for its buck with its healthcare spending, and I would agree that some of this healthcare spending should be redirected towards, these kind of programs that I've suggested here. But I don't think they're mutually exclusive. Like, if you have no insurance or medical care system at all, that wouldn't work. But obviously, we have to make it more efficient. So I feel like I agree with what you're saying that we're spending too much on healthcare in the U.S. That's why I'm talking about the social determinants, that we need to be crafting policies and redirecting some funding towards those policies. But I agree with you that we should definitely need to redirect some of our healthcare spending. But we still need health insurance coverage to. People still need health insurance coverage to afford the medical care they need when sicknesses do arrive. Now, obviously, the point of social determinant policies are, like, for example, encouraging healthy eating so that people, don't end up getting sick, and public transportation cuts back on pollution so you don't get asthma in the first place. So that's part of the point of social determinants is it's a preventative care, so to speak. But you're not going to be able to prevent everything just through the social determinants of health. You're still going to need medical care to attend to your medical needs. So social determinants of health policy should help us, and it should take the pressure off the medical side, so we won't have to spend as much anymore when these ailments come up that we should have been able to prevent by people just eating better. But So I think we just need more of a balance. So. Hope I got the answer there. Professor Jarlow.
I had a thought when you were talking about the intelligence, black-white difference results.
Yeah, I thought you
looked
at
that. Yes. It taught me Inner City was my alternative service since going to Peace Corps, something 5 years in the inner city. We gave all the kids coming in a couple of tests, not a battery of tests, but a few tests, and they did terribly on them. And they did terribly on them because they were mad to be asked to take a test to tell them how smart they were. So that may be why the instruction itself and the insult of it might be why those numbers are different.
Right. So I guess we should also be like, we should be framing. There's a lot of standardized tests we have in our current educational system, and people are like, oh, got 31 in the ACT, so smart. But it's like we're framing it the wrong way. I think with a lot of these standardized tests, where we're saying this shows how intelligent you are, that can discourage people. I feel like, I guess it's a two-part thing. Obviously, both the stereotypes as well as. Making sure that we're not framing these tests in that way. Kaylee, and I'll go back to Professor Kramer there.
Do you think that your plans to address better integration in neighborhoods is going to have an impact on the racial differences that you observed in the literature that you read? Because it seemed like the policies you're proposing were kind of getting at, especially on the transportation, at a more integrated community, because right now there's de facto segregation in communities of negative influence.
Right, yeah. I guess I didn't explicitly draw, but yeah, the public transportation definitely, if we're connecting different neighborhoods more that, have different type of people living in them, predominantly black, predominantly white neighborhoods, if we have more public transportation between those neighborhoods, I think it does tend to lead to more racial integration over the long term there.
So what do you do with the fact that there's evidence that suggests that wealthy black folks who live in integrated neighborhoods have worse health outcomes than black folks who earn less money but live in predominantly black neighborhoods? So a push for integration may in fact have a negative consequence if we take that data seriously.
Well, let's see. I think, what was the explanation? What did they give a reason why that occurred?
Yeah.
Well,
My question would be, what's the base, where did that come from, that statistic, or that conclusion that you just indicated?
I think. Can you repeat what you said again, just so I can think of my response here?
Well, the data suggests, I mean, basically this gets to, I guess one of the larger concerns I have about some of your conclusions, or some of the data that you're putting forth. There's a lot of data that shows that, in fact, income level is not what is relevant to health outcomes, and that what's more important is health income gradient, and so what the level of inequality is in a nation. So if you actually have, so people who live in, so the mere fact of having higher income does not in and of itself lead to greater health outcomes. What's important is that you're living, so stress is actually one of the bigger factors, and it isn't just work stress, it's life stress. So the idea is that upper class black folks who are living in predominantly white neighborhoods or even integrated neighborhoods experience far more stress than their middle class counterparts who are living in predominantly black neighborhoods. And so I think it's important as you're thinking through your policies to keep in mind that it really isn't a matter of income. And I think that the Whitehall study sort of demonstrates that pretty easily, that it isn't just having sufficient amount of income, but that what's important is the amount of income inequality. And if you look from like all the state data and which states have the best health outcomes, that gives you some really good data in terms of it's the income equality or inequality that's important, as opposed to the sort of raw purchasing power individuals have.
Well, that was a long thing. I was just going to say that maybe one of the reasons why those upper class black folks in the predominantly the white neighborhoods, I mean,